Welcome to Healthcare for All's annual conference. I'm Ronnie Shore. I volunteer as president of the board of directors for Healthcare for All Washington. Just like me, you too can volunteer for Healthcare for All. Please consider going to our website and going to our Get Involved spot, or icon, volunteering as for one of our committees, our policy committee or outreach committee or communications committee or development committee. Also, we accept one-on-one support as we do planning for other meetings. So we welcome you to join us for a specific project or offer advice or join one of our committees. In the Zoom chat, in the chat function, we're posting a link to our website where you can find the donate button. And we have set a goal because this is our biggest event of the year of $15,000. If you are able to donate, please feel free to do that. Just go to the chat at any point during the meeting. Also, you can navigate to the Get Involved button to volunteer, to find a place in our organization. So while you're on your website, please look around. You can also go to the chat to add your questions. We will have a question and answer period as soon as Dr. Moran finishes the presentation. We hope to have a conversation. So on our website, you'll see different resources and information, most of which we will present tonight. But check out that website to find our goals, our long-term vision, our strategies to move along the pathway to a true universal healthcare system with everybody in, with complete coverage and nobody out. So add your questions to the chat. You also can find, if you hover over the bottom of your Zoom screen, you'll see a opportunity for closed captioning. I think different iterations of Zoom have different titles, but I think the CC for closed caption icon shows up each time. You can see from the agenda that we will. Can you go back to the agenda slide? Please. We will have first this presentation by Dr. Moran, the new director of the Washington State Healthcare Authority. Then we'll follow that with a Q&A. We have some recorded messages from the chair of the Senate Healthcare Committee, Annette Cleveland, and the chair of the House Health and Wellness Committee, Dan Bernofsky. And then we will have several introduction of several volunteers and our education fund board volunteers. And then we'll have Denny and John will present a summary of our victories over the past year. And then about 3 o'clock, we will switch to a business meeting. So please stay tuned and participate as much as you can. We do know that you want to take a break, so that is allowed, okay? But we'll be here and we'll get started in just one moment. First, just want to acknowledge that I'm participating in this meeting today on Zoom, but from the land of the Coast Salish people. Please take a minute to acknowledge the peoples and the lands where you are joining us from today. We acknowledge all the ancestral homelands and the traditional territories of indigenous people who have been here since time immemorial. We walk alongside these indigenous people who taught us to remember some lessons of life about preserving our lands and our people. We thank the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, the Muckleshoot, the Puyallup, the Suquamish, and the Tulalip tribes. So let me introduce you to our keynote address. We able to get started a little bit early. And Ron, if you can highlight Dr. Moran, he's just moving to Washington. He was the Deputy Secretary of Healthcare and Financing and Medicaid in the Maryland Department of Health. He currently serves on a national basis with the National Association of Medicaid Directors. Isn't that exactly the experience with Medicaid? Isn't that exactly the experience that we need to lead us through this devastating federal and state budget deficits? His career includes leaderships in large integrated delivery health systems. So he's got that experience, including hospital, outpatient, community health center settings. He led a community-based health system that served LGBTQ and HIV community in Washington, D.C. Isn't that the experience in equity and social justice? Isn't that exactly what we need to lead us forward as we're building a true healthcare system in our state? And his research as part of his Doctor of Public Health degree from Johns Hopkins included interventions for people with substance use disorders. Isn't that the experience that early in his career, that's a great sign that we have someone who will make a major impact on our health here in Washington State. So Ryan, let me welcome you to Washington, and we'll share those slides. Thank you.
Amazing. Amazing. Thank you so much, Ronnie. That was a very kind introduction. And I'll just allow everybody who's joined me to recognize me as human after all those very kind words. So it's just a delight and really great to be here with all of you. I want to thank Ronnie for the invitation. And it's a pleasure to be able to spend time with you on a Saturday afternoon really envisioning a world, right, which I think we share the same common value of believing that healthcare is a human right and thinking about how do we advance that particular work together in the complexities of which we find ourselves in, particularly at this moment in time. I want to start out by saying, yes, Ronnie covered a little bit my background, but when I was in the state of Maryland, I worked very closely with the Maryland Healthcare for All delegation, if you will, an organization under the leadership of Vinnie DeMarco, who some of you might know. Vinnie was a dear colleague and a dear mentor, and so I respect this work. I respect the advocacy and the important advocacy, the piece that you play. And I am really, really grateful to be a new Washingtonian. And I am hunkered down for the rainy season, so they tell me. Although last weekend and through the course of this early week, what gorgeous weather that was in terms of the sun. There's nothing like that back east at this point in November. So I'm just thrilled to be here. I thought it would be helpful today as part of the presentation to ground us into thinking about our collective future in a very volatile, complex, uncertain, use your own adjective of the current moment. And before we do that, I think it's really important to first recognize under the healthcare authority, the Washington State Healthcare Authority, of which I've had the privilege to serve with Governor Ferguson to lead, includes really three main components. One, Medicaid as a key source of coverage for 1.9 million Washingtonians. Second, the public employee, school employee benefit programs, which cover about almost 800,000 Washingtonians. And then the third pillar of core to our work is the Division of Behavioral Health and Recovery, which includes most funding that the state receives through SAMHSA for substance use, mental health services. Those elements of work are response towards the opioid epidemic in partnership with the Department of Social Health Services, partnership with the Department of Health, Commerce, Department of Children, Youth, and Families across the spectrum. And so it's really important for me in the first 90 days of assuming this responsibility, one, to be out and about listening, to be joining countless conversations, dialogues just like this one today, to be seeing the work on the ground from our providers. I've been to every corner of Washington And that has just been a gift. Last week was sort of dedicated to community behavioral health system. And so I spent some time in Vancouver traveling to both a crisis stabilization center, looking at our outpatient behavioral health delivery system with members of the legislature in Chair Cleveland's district, and I know you'll hear messages from her later. So it's just been a gift to be all over the state. I'm really taking that in and discerning, given the federal challenges that we have and the distinct changes that are coming federally, of which I will talk about, how we move forward and what do we think, what do we come back to from our own values proposition in this work collectively together. So before I get started on the actual presentation itself, I do want to thank Mary Franzen, who many of you may know. Mary is a key member of our team at the Healthcare Authority, who is over our coverage strategies and works in very close partnership with the Universal Healthcare Commission. And so, Mary, just want to thank you and appreciate you being here. And if there's any question I can't answer, I'm going to pitch it to Mary. No, I'm just kidding. So
Thank you.
thank you, Mary, for being here. And thanks to your work. It's really important. And I'm so glad that we are able to have your talent at the authority. So to get us started, I thought I'm going to accomplish two things today before a robust, I hope, question and answer session. The first is I want to give you a little bit of overview of just in the brief 90 days that I have had to be here in Washington, where I'm seeing sort of the future areas of focus from the healthcare authority's perspective. And then also talk a little bit about some of the realities that we are up against, particularly from the implications of HR1. I know all of you are following that work closely, but I thought it might be helpful to give you some sense of now that has passed. It's hard to believe that it's only been about 100 days ago, July 4th, when it was signed into law. What does that actually mean, and what are the timeframes that the state must be working towards to try to protect and prevent the values of coverage that we all hold? So I will definitely talk about those implications and give you a time frame of the things that it's entrusted with the authority and the state to work on as well. So are the slides up? Okay, perfect. Wonderful. If you go to the next slide. So as I've been talking to members of the legislature, been out and about with providers, having conversations, discussions with community organizations, stakeholders, visiting, I've had the opportunity to visit a number of our tribes as well, participate in the Centennial Accord, so many other different components of listening, the most important component for me, sort of grasp our future. These are sort of what is sort of forming for me, and this is an iterative thing to think about in terms of what's the focus areas for HCA's future. But really, as I've started to reflect, a key principle to my leadership style of discernment and reflection, there were really three sort of buckets that are coming into view or coming into place. And the first is responding to the needs of Washingtonians. Again, as I've mentioned, healthcare is a fundamental human right. And so in this moment, there are some certainly challenges that seek to threaten the healthcare coverage that people in our state rely on. Obviously, a lot of that is predicated upon the changes in HR1 specific to the Medicaid program. And so as we think about what the agency's response is to responding to the needs of Washingtonians, it is all about harm reduction, coverage mitigation, coverage protection for the particular program. Individuals obviously will have more onerous and barriers that will stand in their way from keeping their healthcare coverage, particularly individuals that benefited from the coverage expansion in the Affordable Care Act. And those opportunities will be about ensuring that our front door of eligibility operations, our systems, our call centers, and the delivery system, providers, community organizations, are able to educate people about how that will all be set up so that people don't lose their coverage. And we as a state will need to take the latitude to ensure that the HR1 lays out a number of exemptions of people who don't have to go through those processes that may be part of that expansion group. It will be up to us to ensure that we categorize those expansions or those exemptions in an automatic way so that people don't get caught up in the bureaucratic red tape paperwork that these policies are designed to do. So top goal, right, is to try to preserve and mitigation, protection of the safety net. I know that that is also part of your legislative goals and priorities as you think about 2026 and moving into session as well. So you could not have a stronger partner in that regard. The second is the state is home to, the healthcare authority is home to some of the most important, some of the biggest contracts, both in terms of size, quantity, expectation, dollar amounts, with organizations, particularly health insurance carriers that play an important role for us to provide coverage to individuals. And it is so key, and this has certainly was part of my work in Maryland, but to ensure that we've got partner accountability at the table, the appropriate oversight, ensuring that they are delivering on the strategy of the state in terms of what our expectations are. That oversight, that accountability, that work in partnering with those organizations will be more important than ever as we think about the volatility and uncertainty in our future. Obviously, Congress seemingly just got back to work after 50 days, if you will. But the whole debate centered around cost and affordability in our healthcare system. Obviously, that still looms in the balance in terms of what will happen with the enhanced tax credits on the exchange. Um, and In this moment, even though there's a significant amount of volatility that exists, no one is absolved from thinking about the cost and affordability challenges that we have for consumers at large in every healthcare delivery component of our system, not just some portions of it, but all of it. And so thinking about cost and affordability, using the tools that the state has, the forums that we have, whether it be, which is work I know that you all have supported in the past, accelerating the work of the Prescription Drug Affordability, our Healthcare Cost Transparency Board and the recommendations that they make to the legislature. These are going to be important forums for us to be able to navigate. And I strongly believe that a focus on coverage, mitigation of coverage loss, a focus on partner accountability, ensuring we've got the right people at the table, a focus on cost and affordability will be able to do what we can to help us buoy what is is a volatile time for our delivery system, for our providers, our physicians, our community health centers, the folks who are doing the work and seeing the individuals in terms of healthcare delivery. We will have to do those sort of basic core things right for the delivery system to be sustained. Second priority or thinking of focus areas in our future is closing gaps in health disparities and advancing health equity. As I have been traversing the state, seeing a lot of these services being delivered up close and personal, what I will note and count in this moment is that there continues our work to accelerate behavioral health supports, both in terms of mental health and substance use in our state. Our state, and trust me, in the state of Maryland, I admired this work of the state being integrated from a physical standpoint of health and a behavioral health standpoint of health within the Medicaid program, so integration, ensuring that was all under one roof. And I want to ensure that our state has more than just integrating it from a financial standpoint, but that we're looking at it from the full continuum of care and healthcare service delivery for the patients that receive the care. And that we actually are creating a continuum of care that's well funded from birth to the grave in terms of the continuum of behavioral health service delivery that exists in our state. Maternal and child health care, we owe it to the next generation to have better outcomes. The only new funding that is on the street right now from the federal government is Rural Health Transformation Program. That is funding that was also passed as part of HR 1, and that was signed into law in July. Washington State, 2 weeks ago, submitted an application for $1 billion over the course of 5 years, so $200 million per year. We do not expect as a state to receive the full $200 million per year based on how that application potentially will be scored at the federal government level. However, it will be important funds to try to do what we can to preserve and protect the safety net that will exist in rural communities, although none of those dollars can be used on direct service delivery to offset any of the cuts that will come in rural communities related to the Medicaid loss of enrollment. But it certainly is money that the state is taking very seriously to try to get many dimes as we can in to support and help our rural communities and our tribes. As part of the work, there's about a 10% set aside that will go to tribes to support efforts in terms of health transformation for them as well. Primary care, I'm a big emphasis on ensuring that when we're thinking about the challenges that we have in the delivery system, the base and the floor of it, we've got to put more emphasis on primary care. I've been briefed on the work that the state has made over the course of the past few years, setting investment targets for the percentage of dollars that we spend in primary care. How are we holding our plans and our work accountable for those particular investments in primary care? I know that it will be very important moving forward that that is a sustained system, because we're going to have access and challenges as it relates to individuals who may lose coverage. And so thinking about how do we create a safety net that can support them. And then the Healthcare Authority is also home to the standard bearing work nationally. It's one of the reasons I came to the Healthcare Authority, which was through its Medicaid transformation waiver, which it's used unique financing elements to really invest in social determinants of health, housing, transportation, food, nutrition supports, assistance. It's done things innovatively like keeping kids covered from 0 to 6 through continuous eligibility. They don't have to go through a re-enrollment if they're eligible for Medicaid at some point between 0 and 6 years old. These are all items that, unfortunately, as we move forward in the federal administration that we have, are in conflict in terms of what the federal government may think about how those investments are, or what the value of those investments versus what the state actually had outlined in previous administrations federally that sought approval. Our waiver for those programs is up in 2028, so we'll have to seek a renewal of that work in 2028. And obviously and unfortunately, that will be under the current federal administration to approve that waiver. And so we are trying to think about strategies to preserve and to protect as much work that we can as part of that really important standard bearing national work, as well as some of the most promising outcomes that have come from the Medicaid transformation waiver here in the state. But it is fundamental in terms of addressing social inequities and working to continue to advance not just the healthcare dollar, but the systems at play that plague individuals from achieving full health equity. And then the third bucket, which might seem kind of surprising if you are an external stakeholder to state government, is strengthening agency operations within the Healthcare Authority. This is not on here because of any reason as to think about, other than in order for us to do the basics right, to preserve coverage, to mitigate the harm of HR1, it all comes down to having a responsive state government that when people need to get through those eligibility processes, when they have to find their way through navigating work requirements, how well does the state position its people, its processes, and its systems and its service to be able to deliver to those individuals that will have to navigate these processes? How well does our phones get answered in a timely manner when our providers in the community actually want to provide Medicaid access and need to get through our enrollment processes in order to do that? These are fundamental core operations things that will make or break our success as we navigate what is really volatile policies, what is really volatile operational things that are very difficult to implement. So there's a key focus here on sustaining the delivery system. And I have said multiple times to the legislature, I've said it to providers, that if the state doesn't have the resources, or if the state doesn't focus on executing on those important elements, the delivery system will absolutely feel it. And our goal is to ensure that to the extent that we can, that the delivery system mitigates the harm that they feel from these policies. And of course, HCA doesn't do this alone. We're not the only state agency entrusted with all the things that I'm just talking about, but our partnership with the Department of Health, Department of Corrections, Department of Children, Youth, and Families, Department of Social Health Services, we will place an emphasis as part of being a responsive state government when people won't find a responsive federal government at this moment. Two, ensuring that we are working across agencies in state government to be able to respond to the needs of Washingtonians and to close gaps in health disparities and advance health equity. Next slide, please. So that frames us in terms of just thinking. And again, this is iterative for me. Someone may say something today where I might add new bullets to the list of some things for us to think about. But it helps sort of ground us in terms of the importance of the particular moment that is at play with all of the variables that are on the chessboard, so to speak. I just want to speak a little bit of the state's approach and the authorities' approach on the federal budget, and not the continuing resolution piece, but the budgetary items that passed with budget reconciliation of HR 1. And I think, again, we move into that being about 100 years old plus. It feels like 100 years since we've been able to think about analyzing what's going to happen, how do we figure out how to move forward. And so I have to remind myself that this is all still very new as we sort of spiral into thinking about, oh gosh, we have to move quickly, because we absolutely do. And you'll see that on the compliance timelines in this presentation. But the budget, that provision obviously contained numerous provisions that impact Medicaid, food assistance in the individual market. There are hundreds of thousands of Medicaid eligible Washington residents that will be impacted. The bill specifically, I will say, targets individuals who received coverage under the Affordable Care Act, so adults who received coverage under the Affordable Care Act, by making them go through increased eligibility requirements. Obviously, the work requirements is the one that's talked about the most. But those individuals not only will have to meet work requirements, but they will also have to meet more frequent eligibility checks. So today, everybody in the Medicaid program, with the exception of some children populations, applies once per year to affirm their enrollment. And what this will mean for that population is they will have to do it every 6 months. We know when you add more frequency of redeterminations or enrollments, that people will lose coverage because people they don't get the mail, it goes to the wrong place, they don't fill out the paperwork, it's onerous processes. And not only will they have to verify themselves every 6 months, but they will also have to prove that they are doing work requirements. And I love what Catherine is already saying in the chat, because other states who have gone before us in terms of these particular policies, Arkansas and Georgia, when they've begun to implement them, Georgia is really the only state operational in this sense at the moment, at the current time period. There is added administrative cost to the state. When I talked about making sure that we had people, processes, and systems, we will have to invest in new IT systems. We're not built to set up to get people through these administrative processes at the moment. There absolutely will be investments that we will need to make to ensure that people mitigate the harm of the coverage loss that they have. And then ultimately, at the end of the day, you set up processes where you create different pathways of eligibility. So this eligibility group of expansion adults are going to go after different pathways from other eligibility groups. And anytime you add variation to that, that creates growing complexities for people entering the Medicaid eligibility system, leading right to increased exposure or risk chance of frequency of coverage loss. Next slide, please. Here's all the central policies on the next slide and this is very, very small, but I'm not going to spend a whole lot of time here. But these are all the policies that are really inextricably linked to Medicaid that are in the budget. And I'll just note for a couple of these. So the first, there was restriction for Medicaid to provide coverage for or to provide reimbursement for organizations that were engaged in family planning services and reproductive services. So largely here in our state, that means Planned Parenthood and those that provide abortion services. So Governor Ferguson has made a commitment to support Planned Parenthood in terms of the funding that Planned Parenthood would lose. That provision in the budget is a provision that only is enacted for 1 year. So it's yet to determine what will potentially happen for future years. but uniquely 1 year sort of that provision takes in effect, and that was back from July. And then, as I mentioned, we've been talking, what really hits the main frame of your television stations and in news cycles at the moment is this emphasis on work requirements or the more frequent eligibility checks. But there are also provisions that will mean that there will be loss of coverage for current individuals who are lawfully present. We're not even talking about undocumented individuals, but individuals who are lawfully present that have some type of refugee, asylee, and other non-citizen status. And those individuals will be required to lose coverage in October 1, 2026, so less than a year from now. That's about 30,000 from our estimates of individuals who fall within those categories as we get final clarity on who those actual groups are and how many folks. But we approximate that about 30,000 people just no longer eligible for Medicaid at all. Work requirements we've talked about, the rural health funding we've talked about, the increases in the frequency of eligibility terminations we've talked about. There are also trims around the program that are really important. So currently at the moment, and these are really sort of wonky policy, but they mean a big difference in people's lives. But states had the opportunity for individuals to provide retroactive coverage if individuals were to come in and on November the 15th and say, I'm eligible for Medicaid, and their Medicaid coverage was approved on November the 15th. Then you could go back to you could go back 3 months if there were any provisions of healthcare coverage for that preceding period to cover those expenses in terms of the Medicaid program of coverage. The HR1 has shortened the ability for states to do that. So you no longer can do retroactive coverage of 3 months. Now you can only do retroactive coverage for 1 month for adults that are on the program, and 2 months, right, if you are for our kid population. So those changes make a huge difference in folks' lives and decrease enrollment. And we all know that all of these policies were designed in advance to provide federal dollars to free up tax breaks for more wealthy individuals that were provided from this. So all of this leads to sort of a loss of the federal dollars to support fund those priorities in the Budget Reconciliation Act as well.
Hey, Ryan, can I just throw in a quick question because it won't make much sense at the end. Where are green card holders in this
I see
list?
that. So I want to make sure because the eligibility of non-citizen and those individuals who have certain statuses get really complicated, and there are actually almost 100 certain categories. So I would love to get the commission the list of individuals. We've been able to provide that to the legislature to provide clarity on who's in from those provisions and who's out, and we can follow up with them to make sure that
Okay, great, thank you.
Yep. And then the other thing I'll note here on this slide is that states, one of the HR1 provisions, again, this is a wonky provision, restricts our ability to use financing mechanisms like provider taxes or payments to enhance Medicaid payments to the safety net, particularly hospitals in our state, to sustain the delivery system. And there are fewer ways and avenues of those levers that states can pull to, one, fund the Medicaid program to continue to provide coverage, and two, to really enhance the amount of reimbursement rates that folks are seeing in our state. So that is a huge provision. It is huge financial consequences that will start in 2028, and we'll have to be in compliance of reducing the amount of dollars that we can bring to Washington through those unique financing elements. And then also in 2028, another provision, again, sort of gets drowned out from talking about the work of work requirements, is cost sharing. So it requires individuals to pay up to $35 in that expansion population for services. And what we know when cost sharing is introduced in terms of the delivery system for individuals receiving Medicaid is that they just don't use the care because there's a portion that they have to spend for. So that's another provision, again, that doesn't get a lot of airtime, but is one that we are trying to think through in terms of its implementation, and we'll need guidance from the federal government to do so. And then my last slide, I won't spend a lot of time on it. It's the compliance time period. A few things I would just note here is that, again, coverage losses specifically for Medicaid, the individual market and what's happening with the enhanced premium tax, that's a now thing, right? That's January 1. Individuals, there's real loss of individuals losing coverage from that period. But what's happening on the Medicaid side in terms of HR 1 is, again, back to the first group in October of 2026 are lawfully present non-citizens losing coverage. That's the first group. And then the second is January 1, 2027 work requirements. So the state of Washington, all states have 1 year to sort of make those pathways available to individuals to go live. And so that will require all hands on deck working round the clock effort to ensure that we meet those particular requirements as well. So with that, I think I have provided enough information. If you want to take down the slide, and I'm happy to take any questions that folks may have. And again, I'm just deeply appreciative to be here. Thank you so much for this opportunity, and thank you all so much for your collective work and advocacy.
Thank you, Dr. Moran. Thank you. Thank you. We will share those slides. I know you had details on one of those slides, so we'll share that on our website. So thanks for putting that together. And let me bring up John Sobek to lead the Q&A. John is a member of our board who is a physician, an OBGYN from Bainbridge Island, and has been involved in a number of different levels of healthcare participation over the years. So, John, if with that minimal introduction, we'll talk about you a little bit more later, but with that minimal bit of information, why don't you start with the questions?
Sure. My first question, Ryan, is last time we talked to you, I think the weather was a lot nicer than the last couple of weeks. How are you adjusting to the new wetness?
I'm embracing it. I think that's the word that's the advice that most people have given me, is just to embrace. And so I'm embracing it fully. And love it. Love it so far.
And we won't give you the quiz on how to pronounce some of the cities in our state, like Puyallup and Quileute, and most people would fail that. So first question for you, what gives you hope in these troubled times?
Hope in troubled times. I think I wish everybody would have the opportunity to work with the people who are frontline state workers in this moment. There's almost 1,800, north of 1,700 individuals who work at the Healthcare Authority, who come to work every day with the same values that everybody has on this call to try to preserve and protect coverage in individuals. And it's certainly been, part of my job is to sort of reframe the mission in this moment, because a lot of the programs that people have worked on, that people have built, they're seeing them sort of crumble, fold right in front of their eyes based on some of these federal changes and cuts. But what gives me hope is people are showing up to be part of that mission, be part of that journey to protect people. And what also gives me hope, not only their collective work and mission, and it's just fortunate to lead along their side, is for better or for worse, I'm an eternal optimist. And I believe that the world won't always look like it looks today. And I'm driven by the fact of trying to build a foundation. What is hopeful for me is building a foundation of the safety net in these times, so that when the world doesn't look like it looks today, we come back from that, and we have a floor and a foundation to come back from that on. And I'm looking forward to creating that floorboard.
Great, thanks. Next question. Having extensive experience in Maryland, what are your observations of Maryland's all-payer hospital global budget system?
Great question. Yes, so it's so interesting because I grew up in the coal fields of West Virginia in a town of 84 people, 83 because I left and everyone else stays. And Then I moved from there into Southern West Virginia. I worked in the West Virginia State Senate, which is a whole other story for another day, for a senior member of the Ranking Finance Committee. And then spent a few years in Ohio, and then moved to Maryland, which before coming to Washington was where I spent sort of my whole after schooling professional career. And I started on the hospital delivery system side. I was chief of staff to the hospital president, and then moved overseeing community and population health for 4 regional hospitals in Baltimore. And my charge at that time was actually to help the hospital system meet some of the goals and objectives under Maryland's total cost of care global budget model, which really was emphasized on sort of capping right hospital payment so that you could then hospitals then were incentivized, or there was more incentive to focus on quality metrics, readmissions, so preventing readmissions back into the hospital system, to really focusing in on community-based delivery healthcare rather than sort of the historic heads in beds sort of volume-based approach in terms of the acute care delivery system. So Maryland system is all I have ever known. And so moving to Washington, it's an interesting, getting up to speed on sort of how the rest of the country operates itself. The Maryland system currently, it was a historic waiver program that had with the federal government since the 70s. Under the Biden administration, the work was to create a model from Maryland to introduce that to the rest of the country. So states had the opportunity to select whether they wanted to sort of go the Maryland way or some of the core tenets of the Maryland model. And, with that, that was a very laudable goal to try to think about moving that kind of system to other states. The current moment, it is now transitioned to a program under the CMS administrator at the federal level. So it's governed now by the new federal administration. So there are significant changes that are happening in Maryland. That was happening when I left, happening now in terms of its model and what it was historically and what it will be in the future. I think the core elements, but to answer the question more explicitly, the core elements of incentivizing quality, of incentivizing community-based healthcare service delivery, and thinking about how to sort of change the cost of so much being delivered in an acute care setting and moving it or supporting it within community delivery systems is an opportunity that I think is laudable, and look forward to thinking about, again, once that world comes back, what that future might be in terms of possibility, because there's certainly a lot to learn from Maryland's experience.
Great, thank you. Very thoughtful answer. There's a couple questions that kind of overlap, so I'm going to try to put them into 2 or 3 finite questions. Is it the responsibility of Washington state government to ensure coverage for all Washingtons, regardless of availability of federal funding?
So it's such a great question. Again, healthcare is a human right, and I think at the moment where it's complicated by the federal environment that is at play. And I think we all know, because we all are reading the headlines in our local newspapers in terms of the fiscal constraints that not only the federal government is providing us and the impacts that that's having on the state of Washington, but also the constraints that we may have here at the state level. I think given both of those constraints, and I'll just be clear, this for us at the state level, this changes like by the hour, and there's usually some significant federal announcement that comes out at about 2 p.m. Pacific time, 5 p.m. Eastern time on Friday. Whether that's a change in a grant, whether that's a new audit that they're going after you about for something that goes against our particular values, whether they're asking you to figure out how you cut resources here, these are happening constantly. They're still happening constantly. We read about them and we experience them in getting them. And so I think the opportunity for us at the state level, and what I am laser focused on, is given the amount of resources that we have, one, how do we ensure, again, back to coverage mitigation and protection, that we do everything that we can to keep as many people as enrolled as we need to, given the current system that we have. And 2, how do we think about creating that foundation and floor so when the world doesn't look like it is today, that we can come back from that. And that is, I think, the opportunity in front of us. And that is consistent with ensuring our values of as healthcare as a human right, because we are up against forces that may not potentially believe that.
And then just kind of diving a little bit into, I know we're getting close to time, diving a little bit into options for decreasing Medicaid funding coming to the state. Has there been, from your point of view, any looking at getting rid of managed Medicare, some of the for-profit managed Medicare companies, as Maine did, or moving to a single pharmacy benefit manager as Ohio did? And again, maybe your thoughts about peeling off primary care, funding preventative care, or social determinants of health. How would all that be funded differently? That's
Great.
a long answer probably, but what are your thoughts?
John, how much time do we have? That's my first thought. Great question.
At least 15 more minutes. So keep it up. Keep and keep entering questions in the chat. We should keep going and look at the chat also for reminders about what our website is. But back to you, Dr. Moran.
Yeah, so great questions. Great questions. Let's talk about it. One, I noted on the agency opportunities or the focus for a future, this aspect of partner accountability. So I'll note that in Maryland, the delivery system we had 9 managed care organizations, 9 for a Medicaid population much smaller than the state of Washington. I mean, we had a variety, right? We had for-profits, we had provider deliveries, we had nonprofits, and then we had carve-out behavioral health system where we had one sort of administrative service organization that was fee-for-service based just for specialty behavioral health care. Washington was the envy for me. I admired it so greatly in terms of, one, the opportunity to integrate behavioral and physical health care into managed care, because it's just better for the patient experience in terms of navigating all that. We need to think about opportunities of how do we reduce provider complexities, administrative simplification, et cetera, in the system. But it's going to be a goal of the authorities and a goal of the state to ensure that we have the appropriate level of accountability over those organizations that we rely on to provide healthcare coverage. I think every design and system, when you look at other states, have pros and cons. What I will tell you about the opportunities that the value that managed care provides is that there is an opportunity in terms of the network and the care coordination that it creates. And you have to have the accountability and oversight appropriately from the state level to ensure that that is playing out and being realized at its most highest regard. A fee-for-service structure fully for the state to administer, number one, takes an incredible amount of state infrastructure to be able to build. And I always say to folks, just be careful what you wish for in terms of thinking about that. And two, you have to ensure that you have the most updated sort of systems, protocols, processes that would allow a state the capacity to be able to do that. And so I interact with my colleagues from Maine and Connecticut and South Dakota and other fully fee-for-service states. They've got their challenges. They've got their own challenges too that I'm not sure that we want to invite here into this particular space, but know that we have opportunity to ensure accountability and oversight to ensure that we are achieving sort of the value. And there is opportunity for us to be able to do that, and I look forward to leading that particular work in our state. I think the other questions on primary care and transitioning to preventative care, I'm looking forward to working with our teams. We have a primary care collaborative that brings together both payers and providers and thinking about how can we could advance primary care services and delivery. Again, there's levers that the state has to ensure that we are making gains in those regards. And I look forward to evaluating those and moving forward in those and pulling those levers in the future to ensure that I really view that as sort of a key sustainability aspect of our system.
Great. Since we're on that, a couple questions that just came in, and maybe these are just nuts and bolts operations. What appeals would be available for denials of care? And then a second question kind of related to what you're talking about is, you said it might be complicated building it internally, but is it a belief that the network and care coordination could be done with less money directly by the state? And
Yeah, I would just note, like, I think that there's an incredible amount of value to the care coordination and elements that they have. And again, building that infrastructure at the state level and that particular network would require invested resources and be difficult. I will note that, again, there are pros and cons to sort of every environment that you go down. I think what we really need to take a step back and determine, one, we at the state have an opportunity in terms of inviting partnerships and carriers to the table. So we need to think about the pathways and avenues that we do that and how we do that to ensure that we have the right partners at the table. And secondly, I think that in this particular moment, I just outlaid 4 or 5 years of significant amount of transformation and change that's going to happen for individuals on Medicaid. We have to be very thoughtful and strategic as a state on how much additional complexity and change that we introduce to the market in the short term, or otherwise people will be less off, not better off.
Great, thanks. A couple questions that from earlier on. What would be the purpose of restricting states from adding funds or reimbursements to providers? This seems like this could be fought in court.
Can you say that again, John? I was trying to find that in the chat.
Well, you mentioned about restricting, regulations restricting states from adding funds or reimbursements to providers. What would be the purpose of that?
Yeah, so the purpose is to create. So Medicaid is traditionally, literature facts. It is the one that's the lowest payer in terms of the payment amount to providers. And when you look at sort of the mix and the base of Medicare and commercial, commercial sort of being the buoy in terms of providers of what Medicaid provides. So the purpose of the enhanced rates to providers that states would use, one, if you set up those types of programs, you could get enhanced federal dollars to your state. So if you enhance the reimbursement to providers, not only one, are you thinking about creating more access in the system because more providers accept Medicaid because the rate is higher for the sustainability of that, but two, it draws in more federal dollars to the state. Those levers, those financing vehicles are no longer available for the state to be able to use. They're no longer available for any states to be able to use. The same was true for provider taxes and assessments. Medicaid programs would often tax providers, whether it was hospitals, whether it was nursing homes, whether it was other types of providers within the healthcare ecosystem. And that is you're no longer able to do that. But the reason why the tax was an attractive vehicle to finance Medicaid programs from a revenue standpoint to support the state's general fund support to that was you would tax providers, and then those monies that were used from providers would then draw down those federal dollars. So you're drawing down federal dollars without any state hit because you're receiving those dollars from providers. States no longer have the ability to do that. So it takes away a key funding source by Medicaid.
Ryan's frozen for me.
No, I think I just note I'm sorry, John, I think I'll just note someone that followed up that question with, I would think that maybe that potential provision would be fought in court. I think everything's being fought in court at this moment in time. So we'll just see how those battles play out. But yeah, I think, each one of these, right, all our agency in partnership with the governor's office and all of this is taking a look at sort of the legality of all of these particular issues. It's important as we continue to assess that and think about what our options might be in that regard too.
Okay, great, thanks. And it looks like a couple questions around Medicare Advantage. Medicare Advantage, a number of people are receiving stop coverage letters from the for-profit companies, and what can the state help do that, or can they just get on traditional Medicare?
Yeah, great question again. So volatility in the market of Medicare Advantage, that is a Medicare Advantage. The state does not have direct oversight authority of those particular programs, nowhere the HCA so we don't have a lot of levers, unfortunately, to be able to pull. We obviously are watching those sort of changes in the state closely to sort of understand their impacts sort of downstream to the delivery system at large. But those are not levers, that the state has to be able to sort of control those particular dynamics. I will just note, I think there is, that is why sort of what we do have within the purview and control of understanding what are the downstream impacts to everything that else is happening that we don't have control is important as we move forward in the future.
Great, thanks. This is a broad question, and you're here in front of a bunch of advocates for universal healthcare. What's your view on universal healthcare for Washington State, its current progress, and its ultimate impact? And what will be your recommendations for this movement? And I'll just add, there was an earlier question about stating that the Universal Healthcare Commission doesn't seem to be moving very fast. And maybe in your new role, what are your thoughts about helping accelerate that?
Yes, and so I know Mary is staff to the commission. She's one of my first briefings that I had asked for was the work of the Universal Healthcare Commission, how things were taking place. I think at the moment right now, the Finance Technical and Advisory Group is working on sort of their key design elements of that universal healthcare system, and so I think those will be coming in future reports and discussions that the commission will be able to have. I'm looking forward to diving into what of those recommendations are from the Finance Committee. And I think also, in addition to designing what a universal healthcare system is, I think one of the important charges that the Universal Healthcare Commission has is also finding solutions that are also improving our current system to date as well. And so given sort of some of this volatility and things that we are up against in terms of the challenges that we face, I also look forward to working with the commission on those elements as well. I obviously believe that healthcare is a fundamental human right. And I also know that given sort of the federal complexities that we face at the moment, the other challenges before us, it will be very important to navigate that both thoughtfully and intentionally in terms of, again, back to building that particular floor and foundation so that when the world does come back, possibility will be there for us in the future. And I look forward to working with the Universal Healthcare Commission in terms of their goals and the opportunities that they are putting forth in terms of their recommendations.
Great, thanks. Question just came in. Given that the healthcare authority purchases healthcare for PEB, SEB, and Medicaid with health carriers, are there opportunities to simplify and consolidate contract requirements, such as common network adequacy requirements, prior auth, quality assurance requirements, such as HEDIS?
There absolutely are. And yesterday, I just also facilitated a conversation with our teams to begin to start thinking about that. I think one of the things that's really gonna, those elements that you've just mentioned, sort of the network adequacy requirements, some of which there are federal rules that we as a state will need to comply by, particularly on the Medicaid side, that sort of streamline those expectations and increase the expectations of access in our state. To reduce the ability of providers dropping, particularly from the Medicaid side, the work on aligning quality goals, the work on prior authorization processes, all those are huge opportunities for administrative simplification and to reduce providers from exiting the work that we do. So I am eager about those. And back to the partner accountability, those are the areas that are highlighted that I really see opportunity and think that there is really something there for us to really sink our teeth in.
I think we have time for kind of one more question, and then maybe just to wrap up, your opinion about global budgets for hospitals and employed clinicians, pay for time payment for independent clinicians. So, paying for the time spent with a patient as opposed to just a level code.
Yeah, so I think the other thing that I was lauded, in addition, I mean, I'm obviously coming from a world of global budgets and hospitals, but the other thing I admired about Washington's goals was to get towards a system where a certain threshold or percentage of value-based payment was taking place so that we're just not paying for that fee-for-service realm, but we're thinking about other important elements, quality, care coordination that our providers and physicians are providing. Those arrangements also are through, that's one of the ways that, accountability can be done through our health carriers and supporting them in that particular work. And I'm looking forward to sort of the trajectory of what might be possible in that space, particularly around the work of primary care. of advanced payment model and value-based purchasing, particularly in primary care, and advancing some of the work that's the foundation that's already been done, but that is certainly on my radar and is a goal of mine to look at in the future.
Yeah, great, thanks. Maybe in your wrap up last minute, just kind of based on the questions you got from the group here, any final thoughts for us and our mission?
Yeah, I just want to thank you so much. I hope this isn't our last conversation, so I invite you to ensure that that isn't the case. And I'm looking forward to working with all of you. And I'm so elated, and thank you so much for your time today. And I've said two things to all groups and folks I've met. One, my door's always open, and two, my phone unfortunately always rings. Not unfortunately, but it always rings. And so I invite that kind of partnership across the state in this moment. It will not just be about Ryan and the Healthcare Authority or Ronnie Shore and the Healthcare for All Alliance. It will be all of us because that is what the moment will take. So thank you so much.
Thank you, Ryan. Thanks for taking a Saturday afternoon to spend some time with us. We appreciate it. Uh, and uh, and it won't be the last conversation. So thank you again. And thank you, John, for bringing out these questions. Wonderful, wonderful job. Thank you.